Hello, hello, everyone, and welcome to this month's Research Roundtable. My name is Kyle King. My name still has not changed, and I'm still a sophomore in college. I'm almost there. We just passed the midway point. I'm just waiting for the end of the semester, or spring break, rather, actually. Um, and I'm studying neuroscience. I love learning about OCD and other related psychiatric disorders, but I just don't love reading research papers. It's just not a really fun activity. So, but the conflict is it's really important to stay up to date with literature and to keep learning. Um, so for people who are in the same boat that I am, the IOCDF created this program where experts can chime in and they can teach us kind of the latest and greatest in a particular body of literature, so that people like me don't actually have to do the heavy lifting and to read the papers themselves. As always, I'm joined by my co-host, Jon Abramowitz. Jon?
I do enjoy reading and writing research papers, so I'm a good compliment for Kyle. But really, I'm Kyle's sidekick here. But I am Jon Abramowitz. For those of you who don't know me, I'm a professor of psychology at the University of North Carolina, and I love studying OCD. Love helping people with OCD, learning about OCD, which I'm excited to do. Wait a minute, I should go like this, I guess, with our two wonderful experts. We have a third who will hopefully join us, maybe by audio only, but maybe we'll talk about that later on. But yeah, I'm psyched. I'm always hoarding is not something that I've had a lot of expertise in, so I'm looking forward to doing some learning for the next hour.
Yeah, I was reading through kind of the articles about hoarding disorder to kind of prepare for this, and I realized that I know very, very little about this disorder. So I'm really excited to get the chance to ask some questions to experts. But before I introduce the experts, I do have some disclaimers that I just want to say. First, this live stream is educational and not intended to replace therapy. For treatment-related questions, please work with your provider or contact a local clinician. You can use the IOCDF's online resource directory at iocdf.org/find-help to locate a trained clinician near you. The International OCD Foundation is not a crisis hotline. If you're in a crisis or you are ever feeling suicidal or unsafe, please go to your local emergency room or call 911 or the suicide prevention hotline at 800-273-8255. We also want to create as safe a space as possible, so please be kind and considerate and respectful to one another in the live chat. Everything that you say, all the messages you send will be broadcasted live. They will exist on the internet, so please be kind and considerate. We're all here to learn. All right. So I'm going to start with Dr. Norberg. I always get that wrong. Who, for everyone tuning in, it is 3:50 a.m. where she is right now, or I guess 4 a.m. at this point. So she is incredibly dedicated to this live stream. So a round of applause for her. Dr. Norberg is an associate professor. Associate Professor Dr. Norberg is the Deputy Director for the Center of Emotional Health at Macquarie University. That definitely did not pronounce that right.
Macquarie University.
Macquarie. And the National President of the Australian Association of Cognitive and Behavioral Therapy. She has published over 100 journal articles, book chapters, and commissioned media articles on anxiety, hoarding, and substance use. She has received $2.1 million in research funding, which includes funding from the ICDF to understand the underpinnings of object attachment in hoarding disorder, has delivered 140 plus national and international conference presentations, and 30 plus invited talks from universities and community organizations. In her spare time, she maintains a very small clinical practice. I don't know how much spare time you have. It doesn't seem like much. Focused on helping people to overcome OCD and hoarding disorder. Dr. Norberg, how are you doing?
I'm okay. I'm getting more awake as every minute goes on.
That's good. It would be really bad if it were the opposite.
And I'm a little anxious, so if I forget something because I'm anxious, I'm just going to blame it on the time difference and being sleepy.
Yeah, you at least have a scapegoat. I've been up for like 4 hours and I'm still anxious. And then below me is Dr. Carolyn Rodriguez. Dr. Carolyn Rodriguez is Associate Dean of Academic Affairs, Stanford University School of Medicine, Associate Chair for Inclusion and Diversity in the Department of Psychiatry and Behavioral Sciences at Stanford University, and a consultation liaison psychiatrist at the Palo Alto Veterans Affairs. As a director of the Translational Therapeutics Lab and associate professor in the Department of Psychiatry and Behavioral Sciences, Dr. Rodriguez leads studies investigating the brain bases of severe mental disorders. Her landmark clinical trials pioneer rapid-acting treatments for illnesses including obsessive-compulsive disorder and post-traumatic stress disorder. Dr. Rodriguez also serves as deputy editor of the American Journal of Psychiatry, member of the Research Council of the American Psychiatric Association, member of Brain and Behavior Research Foundation Scientific Council, and scientific and clinical advisory member of the International OCD Foundation. She's won several national awards highlighted by organizations including NPR, PBS, and the New York Times. Carolyn, I also don't think that you have a lot of spare time.
No, but the good thing is if you're having fun while you're doing it, then it's okay.
Yes. Agreed.
I'm very glad both of you can join me and Jon here today to talk about something that apparently me and both don't know very much about. Another guest, Dr. Randy Frost, may possibly be joining us. He's having some technical difficulties at the moment, but hopefully we'll see his face appear soon. But while we're seeing if he can make it onto the stream, I want to kick it off because I have a lot of questions. And I was thinking about where to start, really. And I wanted to start at the broadest point possible. So for either of you guys, what is hoarding disorder? What really characterizes this disorder?
I'm happy to jump in. I know. So hoarding disorder has, as defined by the DSM-5, is a disorder for individuals who have difficulty parting with their possessions, and it causes a lot of distress. And that difficulty parting with distractions can result in clutter that can fill up the living spaces and make it difficult to do things and use the rooms in the purposes they intended. So it's difficult to sleep in the bed, it's difficult to cook in the kitchen, this kind of thing. And it causes a lot of distress and impairment. And so, Melissa, if you want to add to that, and I have Randy on the cell phone, I'm just gonna answer this. Hey, Randy. Hey, Randy, we just got the question of what is hoarding disorder? Would you like me to put you on speakerphone?
Sure, that would be fine.
So you could join. Should we try it?
Yeah, do it.
Sure.
Okay, great.
You're on mute, Dr. Rodriguez. We can't hear you.
Okay, let's try it again. Randy, say testing 1, 2, 3.
Testing 1, 2, 3.
We'll take it.
Yeah.
Okay, it works. So we're joined by Kyle, Jon, and Melissa, and I just answered sort of a broad question of what is hoarding disorder, and Melissa was gonna jump in.
I think Carolyn did a great job answering it. I think the only thing I would add is talking about the reasons why people save if it's hoarding disorder. So there's a intense emotional attachment to objects, and that's what's leading them to have difficulty discarding them. So they feel like they might be a part of their self and really define who they are. So it's scary to let them go, or perhaps they really feel like they're going to need everything someday. And they're scared about needing them and not having them. And so that causes that difficulty to discard. And that's much different than if somebody, let's say, is just really depressed and doesn't have the energy or motivation to get rid of objects. That wouldn't be hoarding disorder.
Okay, so is it defined by kind of this mental attachment to the objects in addition to the behaviors? You need both?
I would say the object attachment is the cause of the problematic behavior.
Okay. And just thinking about it in relation to OCD, because that's a disorder that I'm a little more familiar with. Do people with hoarding disorder, do they experience kind of these thoughts when they get the intrusive thought that I feel like my identity is attached to this object? Do they experience that as an immediately anxiety provoking thought, like someone with an intrusive thought in OCD might? Or is it something that doesn't produce anxiety and it seems to be producing anxiety for the people in their lives because they keep accumulating objects?
That's a good question. I would maybe let Randy go.
Randy wanted to field that one. Go ahead, Randy.
If I can jump in here, the interesting thing about it is that, you know, if you compare it to OCD, where it's a reaction to a thought, a negative reaction to a thought.
Mm-hmm.
But in hoarding disorder, the negative reactions to things don't come about with the collecting of things, with the acquiring of them. The negative thoughts come about with the attempts to discard. And the discarding part is where people run into trouble, but it's the collecting part that's just as much a part of the disorder, because their home is filled with things, and those things don't necessarily produce these negative thoughts. In fact, many times they produce positive thoughts. There are negative thoughts associated with the clutter and dysfunctionality, but the attachments to these things are largely one of two things. Either they're pleasure motivated, or they're an avoidance behavior. An avoidance of things like loss and guilt and distress that are associated with letting go. So it's a funny kind of disorder. It's not quite the same as a negative reaction to the symptom, because the symptom is all wrapped up with the acquisition of the possession and the keeping of the possession.
Okay, so it does seem like the keeping of the possession really isn't the stimulus that causes anxiety.
Say that again.
So the anxiety doesn't come from keeping the stimulus. It comes from someone else trying to get them to discard it.
Someone else or their attempts to discard. But in many cases, it is an avoidance behavior. So they're avoiding the loss of something. And the loss is more than the loss of the object. It's a loss of what the object means. So for many people with hoarding disorder, the object has its essence is that it contains something like a memory that they fear they will lose if they get rid of the object. Or it contains something like an opportunity to forge a new identity, for instance, that will be lost if it's let go. Or the object contains some kind of responsibility, so that if I throw it away, what I would experience would be guilt at having wasted something that is of value. So in essence, that these possessions are sort of capsules that hold meaning that is related to the person's emotional self and identity.
So in my head, that makes me question kind of what's going on in the mind of someone with hoarding disorder with regards to the clutter around them. Do they kind of experience these symptoms as like negative and impairing? What's the level of insight?
One of the things that we've seen is a funny kind of, probably it's a sort of habituation to the situation. So for instance, one of the first people I saw with hoarding disorder once told me, and I visited her home a number of times to work with her on this. And one time she told me that if I'm not there before I show up, she feels okay and doesn't really notice the clutter. Mm-hmm. When I'm there, she notices the clutter and she feels depressed. She feels awful and she wishes I would leave. And then when I do leave, she doesn't notice the clutter again and she feels okay. So is it a perceptual problem where she's blind to the clutter? We do talk about clutter blindness sometimes because we see this in hoarding. Or is it an adaptation for her, an avoidance behavior, that she cognitively avoids thinking about the clutter because when she notices it, she feels badly?
Can I add to that?
Yeah.
So at Macquarie University, I have a lab, and I had a living room made for me, and I filled it full of clutter so I could look at the effects of clutter on behavior. And one thing that I've noticed just personally is when I started filling it up with stuff, it would really bother me to go in there. And then as months turned into years, I can now go in there, not that I do, because it's all the way across campus from my office, but I could go in there and sit on top of the clothes on the sofa and watch TV. Like, it doesn't bother me anymore. So I think it likely does. There's this adaptation that you're slowly, it's not like one day you just walk in and you have a house full of clutter. It takes time to build, and you just don't notice it, and then you just learn to live around it. And so I don't think it's that people don't see it, it's just they have habituated to it being there. And I think what Randy's talking about is perhaps that he's changing the context, a new variable's added, and then that makes them pay more attention to their surroundings and see that it might be problematic.
Okay. And then I was also kind of broadly curious to know the history of this disorder in relation to OCD, because I know that originally it was just a symptom, right? Or was considered just a symptom, and now it's its own full-fledged disorder. So if you could tell me a little bit about that.
Do you want me to do that, or Randy?
Or I'll pitch it to you, Melissa, because I think Randy's still trying to figure it out.
Okay, so yes, you're right. In the early days, before I started studying hoarding, people thought it was a symptom of OCD, but the research over the years has just kind of shed light on that. It's different. People respond differently when we do experiments. So hoarding can be a symptom of OCD. So once I worked with a child who had really a lot of difficulty throwing stuffed animals and other toys away, and that's because she feared that they were going to turn alive and come and hurt her and her family once she did that. So that's an OCD reason while somebody's hanging on to possessions, and that's not that underlying excessive object attachment that we see with hoarding.
Yeah, it's interesting. And some of the folks that I've worked with, it can be difficult to tease that apart. I've worked with folks that are afraid of, like, what if I throw out something important like a dollar bill, or well, not $1 bill, maybe like what if there's a $50 bill in my trash somehow, and I throw it away, and they would end up kind of going through stuff. Is that an OCD obsession, or is that hoarding? And I mean, the treatment really, I don't think good cognitive behavior therapy depends on what you call it, right? Because you're going to do a functional assessment, functional analysis. You're going to do, whatever cognitive behavioral techniques, regardless of, what we call it. But diagnostically speaking, if for what that's worth, it was kind of interesting to think about. Is this hoarding? Is this OCD? Is this some sort of combination? I don't know.
Yeah, I think Jon points out a good point that sometimes it's hard, but I think it's like that with most DSM diagnoses, that there's not clear boundaries all the time, and you do the best that you can.
Yeah, and I guess this kind of sets me up for the question that I really want to ask. I was blown away by reading about our current treatment of hoarding disorder, and how it seemed like, CBT doesn't work for hoarding disorder quite like it works for OCD. So for both Carolyn and Melissa and Randy, when he joins, what does treatment for hoarding disorder look like right now? And yeah, let's start with that.
I can let Carolyn go since I've been talking a bit.
Okay, great. So yes, I think that when I was a resident, and I was in the OCD clinic and I was recruiting for my studies, one of the things that I noticed is that for OCD patients coming in, we had research trials and recommendations, but people with hoarding disorder were excluded from research studies. And oftentimes they would call me and say, I'm about to be evicted. And it was a challenge back then to sort of understand even how to treat individuals. And Randy Frost is, really the pioneer of, in the 1990s, his work developing a cognitive model of OCD with Tam Hartle. That was one of the first sort of published descriptions of it, even though historically hoarding behaviors have been in the literature for a very, very long time.
Mm-hmm.
And that, it was only until recently that it became an official disorder in DSM-5. So, we currently, in terms of treatments, you can think of psychotherapy treatments and psychopharm treatments. And it's jaw-dropping to me that there's no FDA treatment, pharmacological treatment for OCD. And there really have only been open label trials of different kinds of SNRIs for hoarding disorder. So it's really, an open area of investigation. Now,
Mm-hmm.
for cognitive behavior therapy that has been modified and adapted for hoarding disorder, there's a very good evidence base of individual cognitive behavioral therapy, group therapy, and Randy Frost and Lee Scher and David Tolan adapted from a book that they wrote called Buried in Treasures. It's a peer self-help support group, and it seems to have as equivalent efficacy as CBT. And so it's a low cost, very disseminable type of therapy.
Mm-hmm. And I hate to take the spotlight away from Randy about his work before he gets here, but you mentioned that he constructed kind of the first cognitive model of hoarding. And what is that model, and how does it kind of apply to CBT for hoarding?
I will definitely defer to him. This is his model, so when he joins, I think it's best for him. But I can just maybe highlight some unique features, right? Of
and
which is for example, in the way he conceptualized it, there's sort of acquiring. So bringing in items contributes to the clutter, as well as difficulty discarding, and then the clutter itself. And there's a lot of different reasons why people can acquire items. But one of the treatments is actually doing exposure-based field trips, where you actually go to flea markets and try to not acquire items. And so I think that is a really powerful modality. And as I've learned more about the field going forward, it seems like, sort of tackling that piece first, the acquiring, is
Mm-hmm.
really important therapeutically. If you start with the difficulty discarding and you don't sort of stem this tide of things coming in, it can be a little bit more challenging. I'll defer to Melissa if she has additional thoughts.
That was great.
I'll add also, there are behavioral experiments or exposures with regard to discarding things. So people have predictions. People, who hoard might have a prediction. If I were to throw this, I don't know, this greeting card away that my sister gave me for my birthday 15 years ago, I wouldn't be able to go on, or my sister would be upset with me, or all these things. And then people have a chance to test out those kinds of beliefs.
Mm-hmm.
Maybe even by saying to your sister, would it be okay? What do you think if I put this card away? Right? The sister would probably say, oh my goodness, yes, no problem with hoarding. I would love you to do that, rather than, no, you're a terrible, family member. Or seeing that you can discard and still, you're going to feel uncomfortable, but you can kind of do okay with that. That doesn't have to be something you avoid.
So is kind of the crux of treatment for hoarding now exposure?
That's definitely a part of it. So there's, we often think of it as there's exposures and behavioral experiments. It depends who's carrying out the treatment. So some clinicians might just really focus on getting people to realize that their anxiety or sadness decreases over time when they're discarding. Others may do more of Jon's approach, where you're testing out your beliefs. I think it's probably helpful to do both in combination with people. And also to point out, when Jon was talking about just throw away the card, what's really hard about hoarding is getting them to throw away that card to test out their beliefs. And so one thing that I've been working on with Jess Grisham is how can we improve CBT for hoarding? And our hypothesis is that we really need to give people skills in emotion regulation before we can ask them to do these exposure behavioral experiments, and we've trialed our approach, and it does seem like it might possibly be more effective, but we definitely need to run an RCT before I can make that claim.
So does this kind of idea of needing that emotional regulation, how does that differ from, I have OCD, and when I was psyching myself up to do exposures, like I probably would have needed some toolkit for emotional regulation myself. So does it seem more needed in hoarding disorder?
Perhaps, and I think it's maybe on an individual basis, everybody's different. So I hate to make a claim about everybody who experiences hoarding disorder needs help. And I also think that behavioral.
There he is.
Hey,
Randy.
sorry about that.
No problem.
Good to see you, Randy.
Good to see you guys.
Yeah, you're
Nice to see you, Randy. Kyle asked a question originally about what is the, I was saying that you were the pioneer in this field, and his question was, what is the CBT model that you pioneered early in your career? And Melissa and I were just providing some different perspectives, and Melissa was finishing talking about her research, and I think there was a question to Melissa, so we might circle back to you, Randy.
Okay.
I'll get back to you in a second, Randy. But Melissa, you're talking about the need for emotional regulation?
Yes. So I was saying that I don't want to make any generalizations because we have to look at everybody differently. But in general, they might need more support. It seems that the research that's been happening in the past few years is that individuals who hoard often have an anxious attachment style, which tells us that maybe they came from homes where they didn't learn how to regulate their emotions and how to support themselves and other people. And so we might need to focus on that a bit more than maybe the average person who experiences OCD symptoms.
Okay. And what's an anxious attachment style, really?
So an anxious attachment style is basically the belief is that when you're a small child, an infant, that we need people to take care of us. And our caregivers can respond in various different ways. When we get distressed, they can always be there for us and soothe us. And through doing that, we learn how to soothe ourselves, and then we learn how to take care of other people at the same time. But perhaps our caregivers aren't all that great at that. Perhaps they only haphazardly respond to us. So sometimes they just let us cry it out and they're not there for us. Other times they are. And that might teach us that we need to react really intensely in order to get people to listen to us. And so that's kind of the thinking behind an anxious attachment style, is through our learning history. We've been trained that if we want people to soothe us, that we need to get really, really distressed. And so that might lead to when we're adults, that certain stressors may happen and we may seem to get more distressed than other people. And it's because of that learning history. And then at the same time, we don't really know how to take care of that ourselves because nobody's taught us those skills.
Okay. So does that kind of like tracing back to how you were raised, is that unique to a hoarding disorder, or might that be applied to OCD or other anxiety disorders?
Research has shown that it definitely is a contribution to many, many mental disorders.
Okay.
So there's still something else that needs to happen, I think, for it to be hoarding disorder versus OCD versus substance use. There's some other part of a person's learning history. And with hoarding, it's probably that they've learned that possessions help to soothe them.
And Randy, I saved the big question for you. So what is kind of the original CBT model for hoarding disorder that you developed? And how does this differ from CBT for OCD, if it does at all?
Well, the model itself was a model designed to try to incorporate at least the early information that we knew about hoarding. At the time we started out, it was mostly based on one case, which was kind of interesting. It was a woman who seemed to display everything, all the classic signs of hoarding disorder. So in that sense, it was a great case. But there were some background, some vulnerability factors that we identified with her. But that the main things that came out in terms of putting together this model included information processing deficits. And they ranged from attention problems, attention deficit problems, to the ability to categorize things. Most of us live our lives categorically. So we have a utility bill, and we if we want to store it somewhere, we put it in a larger category unit, like a bill category or a folder, and then we put it in a file cabinet with all kinds of other information. And if we want to find that one item, we go to each category all the way down to the item for electricity bills, for instance.
Mm-hmm.
But for people who hoard, I mean, the people we observed, especially early on, they didn't seem to organize their world that way. The world was organized visually and spatially. So if you asked the woman we started with where this electricity bill was, she'd say, well, it's in the pile about a foot down, because it was a month ago that I saw it.
Yeah.
So her world, her possessions were organized visually and spatially and not categorically. And this is a part of the way in which information gets processed. So there were some information processing deficits like that we observed. Okay. And then we observed the attachments to possessions that were no different really than the attachments that the rest of us form, but they were more widespread and more rigid. And they were associated with avoidance conditioning features. So getting rid of something was a really intense experience. So, for instance, the one we started with, she was an art history major in college, and we worked one day on getting rid of some of her art history books. Now, they were 30 years old, and she picked up one and she put it in the cell box, and she said she started crying, and she said, it feels like I could just die. This really, really intense emotion. And so if I wasn't there and working with her on this, she would clearly have kept the book. So she would have avoided that emotional trauma, that emotional upset, by saving that possession. And so that the avoidance behaviors are part of what keeps this thing maintained. And then as we continued this experiment where she was letting it go, she covered it with a few other things. And then 10 minutes later, I asked her how she felt. And she said, it's not so bad now. It doesn't really bother me that much. So that going from a really intense emotional state down to one that doesn't really bother her very much in a very short period of time says something about the nature of these attachments. And maybe cycling back to what Melissa was talking about a few minutes ago, the nature of attachments to people and things may be such that it's highly emotional, yet at the same time highly fragile. Mm-hmm. And so for her, letting go of this thing felt like it was letting go of a past. And we've had other people say things very somewhat unusual things like, if I let go of that, not only am I letting go of the past, but I'm letting go of the ability to remember the past. And if I can't remember it, it's like it never happened. So the fear there is of a loss of some kind. And that in the cognitive behavioral model we started with, that's one of the kinds of emotional attachments that we talk about, is attachments that are related to this sense of loss, a sense of identity, really. And I think a number of folks, Melissa and Jessica Grisham and those folks in Australia have been focusing in on these attachments quite creatively. So that's a part of it. And they all go together in this sort of reinforcement pattern. And that's sort of the general outline of the cognitive behavioral model. In terms of treatment, mm-hmm. the treatment is a little bit different, and it doesn't rely on strict exposure, but rather on the processing of information about these possessions. Because one of the things we've observed is that once the possession comes into someone's home, it is seldom interacted with again. It goes into a pile somewhere, and with attempts to clean, it might move from room to room or move from pile to pile, but there really is never any attempt to truly evaluate how important this possession is for them. Mm-hmm. And sometimes the simplest thing we can do for someone is just sit with them and ask them to tell us about a possession, and then make a decision about whether it's worth keeping. And many times that's enough. and they can let go of it. Now, it's a slow process, and sometimes it takes a long time for them to get to the point where they can do it quickly. But that's quite different than OCD. And the other thing that's very different from treatment of OCD is how we deal with the excessive acquisition. Because here we're dealing with more positive emotions, because the shopping experience is a high. And many people with hoarding tell us that it's their only source of joy. And so
acquiring more things, that is.
Acquiring things, yeah. So if two things: one, how do we deal with that? Because we want to take away their joy, and secondly, what do we replace it with? And so those are two features in therapy for hoarding that are much different.
So so hoarding is maintained by both some positive reinforcement and also negative reinforcement, avoidance, which sounds different than traditional OCD.
Yeah.
So I kind of have two follow. Or does anyone want to add anything first? Carolyn, I thought you might have said something.
Oh, I didn't say anything, but I can add just that when I did this work in New York City in eviction intervention services, one of the challenges is how do you help people when their home can be hazardous, right? There can be so much clutter in people's homes who are at risk for eviction that it might actually topple over, and there are real concerns about fire hazards. So one of the things our lab is working on is how do we help people in the spirit of what Dr. Frost is talking about, but in a safer environment. And so we're testing out virtual reality uncluttering, where we can scan people's items into sort of a virtual world, and then with their therapist they can sit sort of in a virtual world, and they can hear about the items, and they can kind of decide. And there's different bins, right? There's the recycle, there's the donate, the discard, and keep, right? And when they're in the world and making the decision, if they decide to discard something, there's like a sound of, and you can actually see the truck come, take the item and take it away.
That's great.
Yeah. So different modalities, because there are real risks, right, to therapists being able to enter the home sometimes.
It is striking too when you see someone throw something away that is so dear to them, because the emotion is just really intense. And so it's quite surprising for someone who doesn't ever have that kind of feeling about getting rid of something that's old and many times not useful.
So what's kind of the thought behind, like, what's happening in a person with hoarding disorder's mind when you can just talk to them about the object and then it gets easier for them to just discard it? Just the fact that they're talking about it.
Yeah, it's interesting. When we put together the first attempt at treatment, we created a set of Socratic questions to go along with this process. So the idea was the therapist would use the Socratic questions to get them to process the information about the object and make a decision. And so we then did a test where we took people who were in treatment and used the Socratic method, and then our control group was just having them talk about the item for 4 minutes, and then we looked at how often they threw the item away. And what we found was they were actually a little bit better at throwing things away if we didn't ask the questions, if we just had them talk for 4 minutes. And so, it led at least me to think, well, maybe this is just a function of their so much avoidance behavior going on when something enters the home that they never consider throwing anything away. And once they do, in some kind of structure that allows them to talk about it and to really talk about both the pros and cons, it gets easier for them.
And then when it comes to kind of the second part, where you have these positive emotions associated with the acquisition of objects, what kind of techniques do you have to kind of break that positive association, right?
Yeah. We have two ways we do it. One is when they're in the office, we ask them to put together a set of questions that they think they should ask themselves before they acquire something. And what they come up with is largely what all of us would. Do I need it? Do I have money for it? Do I have space for it? Do I already have something else like it? And so forth. And then we have them in our workbook. We have this as a cutout, and we have them cut it out of the workbook and carry it with them. And if they're somewhere where they're in an acquiring environment, we have them pull out those questions and answer them. And then they make a decision about whether to acquire this or not. And what this does is it brings the context of their life back into the decision making, because the acquiring behavior in hoarding is largely driven by the focus of attention at the time of the acquirement. So their focus of attention is so narrow that the only thing they can think about is how lovely this thing is and how wonderful it would be to have. And all the information about the context of their life. Do I already have one? Do I have money for it? Do I have space for it? None of that information is available to them in terms of making a decision. So what we're doing is bringing the context of their life back into the decision-making process. And as we started this, we noticed that we were pretty sure it worked, because when Gail Seketi and I were working with this initial group treatment, we were sitting behind a one-way mirror watching the group, and our therapist had just gone through this exercise the week before about the questions. And during the session, there was a break, and everyone got up to get coffee, but two of the participants in the group were sitting there, and one of them said to the other, I went shopping last weekend, but I didn't bring my questions with me because I knew if I did, I wouldn't buy anything. So we know it works. People just have to engage in it. So that's one feature of it. The second has to do with how people control the urge to acquire, because it's very impulsive, and it's very hard to resist this urge to acquire something when people are out. So we treat it much like we do a physical fitness paradigm. You know, if you want to learn how to run a marathon, you don't go out and run 20 miles the first day. So we create a hierarchy of situations where the urge to acquire increases in intensity. And might start by what we call drive-by non-shopping. They drive by a store and don't stop. And then build up their ability to tolerate that urge as we go forward. So that's the second way. And then the third thing we really have to do when we do this is help them come up with other ways of finding joy, because these are the pleasurable activities that they engage in, and letting go of them, especially with a disorder that's associated with depression, is something we need to be careful about.
And Melissa and Carolyn, do you have anything to add about kind of changing the way you process information in hoarding disorder?
Randy's did a really great job explaining it. I guess I would just add, since I come from a substance use background, is that the pleasurable properties associated with hoarding seems to me a lot like a behavioral addiction. And so thinking about how do we help people with addictions, and so it's just what Randy says is we have to teach individuals to build up their tolerance to avoiding cues. And so in substance use, when people repetitively use a drug over and over again, the drug starts to elicit less dopamine when they take the drug than somebody who's drug naive. So they're getting less hit from the drug. But what we see is that the cues become much more powerful. So if you put them in a scanner and you show a drug naive person like a cannabis bong, and someone else who regularly uses cannabis, that picture of the bong in the scanner, what we see is that cue elicits much more dopamine in the person who regularly uses the drug use. So there seems to be this transfer of what's salient to an individual. And so with hoarding, I think it's just that it's showing them their cues over and over again so they can that attention that they have to those cues will lessen over time if we repetitively show them the cues in the absence of acquiring it. They'll break up that connection they've learned. If I see this cue, I must take it home. If I see this cue, I must take it home. Well, let's see the cue, not take it home. And if you do that over and over again, and while you're doing that, focusing on, you can tolerate this. Look at how great you're doing. You didn't die. You didn't lose who you are. You didn't lose that memory of when you were with that person shopping or on that holiday, and it becomes less powerful.
Mm-hmm.
I would also add that in terms of the connecting aspect, when you do the cognitive behavioral group treatment, it's also really you see the joy that individuals who suffer with hoarding disorder feel when they see other people that suffer similar difficulties, and there's a sense of like connectedness, and a lot of people can strike up friendships in that group, go on to, like, even after the therapy is over, continue to meet. They help each other, going to each other's homes and helping them. And so in some way there's just really this lovely shift to a focus on the connection with the item, and really through the group process itself can start to form those connections within group. Another piece is just the isolation that people feel, right? Which is a lot of their family members don't, are upset with them and don't know that this is something neurobiological and really in a disorder like a heart attack or cancer or something like that, and assume that it's something that the individual just doesn't want to help themselves, and so they can feel very lonely, and rebuilding that part of their lives can be very helpful.
Mm-hmm.
I think another thing that's important here is, and it relates to the motivational piece, and it harkens back a bit to Melissa's comment about substance abuse similarities, is here are people who have, by and large, suffered decades of criticism for their behavior, fractures in their family, relatives who won't speak to them, won't visit them, who get frustrated with them, who've given up on them. And now they come into therapy, and how do we respond? And largely what they've been told is that their stuff is all junk and trash, and they don't believe that. And so for the therapist, I think you've got to start with an appreciation of what they see in these possessions, to appreciate the values that they bring to this particular item. And then from there, once you can understand the value they see, then it's much easier to work with this other question of, well, what's the relative importance of this thing versus the context of your life? It's a much easier equation if you start by understanding and appreciating what they see here and their value for this unique physical object.
Mm-hmm. Well, first, I was just about to ask, what's like the first step a clinician should take? So, Randy, solid job getting that question out of the way. Jon, do you have any questions? Because I have a few more.
No, I'm loving just hearing us all you guys all discuss this. I'm learning a lot.
So after that initial appreciation, kind of what do you tackle first? If you're a clinician and someone is presenting as having hoarding disorder, because it sounds like, at least when I went through ERP for OCD, my clinician, who I love, was just like, exposure. Like, let's not talk about your feelings. But this might need to focus a lot more on the feelings.
Yeah, I think what I like to do, or what I recommend, is starting with acquisition. Because until you get control of that, even letting go of stuff, you're not going to keep up unless you can slow down that acquisition. Acquisition is a little easier to deal with, I think, because it's not so raw, and it sort of sets up some successes early on. So,
Mm-hmm.
but I think it depends too on the particular client and where they're at with things, because some people are in a crisis situation and you need to approach from a different angle.
Melissa and Carolyn, any kind of like recommendations for initial approaches? A lot of our viewers may be clinicians, so.
One of the things I've been doing recently, and I think Randy's already touched on this, is just figuring out why they have difficulty discarding. And so often what I see is individuals have a lifetime of people telling them they're not good at making decisions. So they start to doubt themselves, and trying then to find examples of where they have made decisions in life and where that's worked out, and to build their confidence that, yes, you can make decisions. You actually do know that you don't need 500 black shirts and what to do with them. And you can be confident in that decision and not doubt yourself. And I think that can be really rewarding to have someone, maybe for the first time or in a long time, really believe in them. And so it's being their support person.
I would second Randy and Melissa's excellent comments. There's another researcher, Chia Ying, who does a compassion focused kind of a twist of the cognitive behavioral therapy, and exactly as Melissa said, helping the individual in ways and to give kindness to themselves when they have experienced a lot of suffering in their life, just based on people not understanding, what's driving them.
Mm-hmm. And I've heard a lot more mentions of group therapy than I was anticipating. Is this uniquely efficacious in hoarding disorder relative to like OCD or any other psychiatric disorder? And why might that be if it's the case?
I think there aren't any really good comparisons between group and individual. They both seem to have the same sort of efficacy rates, or at least approximately the same. I think the thing that the groups do, a couple of things. One is it carries with it some degree of accountability, that people come to the group and they're supposed to have done something during the week, and they share that with other folks. And also this sense of camaraderie, because for the most part, people with this disorder have never met another person with it. And so they're out there all by themselves, and they think, now it's a little bit different, but early on, people would tell me, I always knew there was something wrong, but I never knew what it was called. And I didn't know it was a disorder. And so there's some kind of extent to which they're understanding with each other, and they can empathize with the other people in the group and what they're going through. And for that reason, I think it makes a difference. So, and the other thing, we collected some data on our Buried in Treasures workshops, which is a certain number of sessions people go through a workshop on hoarding. And one of the major things we find, not only we find improvement in symptoms, but we find an increase in hope. And I think that's an important feature of a group therapy. Now, maybe that happens in individuals as well, but I think from seeing other people struggle through it and understanding their perspective, there is some degree of hope that people come away with.
In OCD, one of the challenges of doing group therapy is it's so heterogeneous. You got the people with the washing compulsions and the checking and the intrusive thoughts, and hoarding seems like it's a little more homogeneous. I don't know. What does the panel think about that?
Well, I think in terms of the basic symptoms, it is. Now, the attachments vary, and some of the other things vary a bit, but the fact that all of them have difficulty discarding, virtually all of them have acquiring problems, and all of them have clutter. So in that sense, they're really all in the same boat. Now, there are some differences in some of the specifics, but in the main characteristics, they're all pretty much the same.
And we're getting a lot of questions in the chat about how you deal with OCD and hoarding if they're comorbid. So if anyone has kind of a general thought about that, or all of you guys have general thoughts about that.
Well, what I can say is that it in part it depends on which one is more primary. But sometimes I've had some cases where as we dealt with the hoarding, the OCD symptoms lessened. And that was partly because there's some natural exposure. So one of the first cases of the person who both had OCD, and in particular contamination fears and hoarding, and are working through the hoarding issues, required her to touch and get exposed to things she wouldn't have otherwise. And so it probably was a natural kind of situation where the OCD got treated along with the hoarding.
I'll respond to a question that's a little bit off topic, but I think it deserves mention. I know of no evidence that there is any relationship between the COVID vaccine making OCD worse. I don't know if anyone else on the panel does, but it sounds like the person has been asking this question. As a public health person, I think it's important that we at least throw that out there just for a second. But I know of no evidence to suggest that. Melissa, Carolyn, Randy, you guys aware of anything?
I saw reference. Now, I have not seen the study. All I saw was a one-line reference somewhere to a study that's just come out somewhere. I don't even remember where off the top of my head, that hoarding behaviors got worse during the pandemic.
That hoarding behaviors, yeah, but with respect to the vaccine.
Oh, with respect to vaccine, yeah. No, I haven't seen anything related to the vaccine per se.
Okay. I just wanted to, I think that's important because people should get vaccinated.
Oh, yeah.
And we'll go back to hoarding. Sorry.
Yeah. Melissa and Carolyn, do you have any kind of thoughts about the comorbidity between the two, OCD and hoarding?
I think it just goes back to what Jon said at the very beginning, is that when you work with anyone, you really should be doing a functional analysis to see what's driving all their behaviors. And then you use that information to tailor treatment to the individual, which can be hard in group therapy because there's less individual time. So someone who has comorbidity, they might benefit more from individual versus group, or maybe they need to do both at the same time. Unfortunately, we don't have really great data, but just knowing how do you do CBT well, it's you need to do that functional analysis and tailor treatment for that individual.
Mm-hmm. And kind of what does the efficacy of CBT for hoarding look like?
Well, okay, I'll go. We do know that it works, but the data are not as good as they are for OCD. We get changes in symptoms of 30 to 40%. We get 30 to 40% of people who are clinically significantly changed, but for the most part, the majority of patients, when they finish treatment, still have some hoarding symptoms. So we have not solved the puzzle of exactly how to treat this disorder. We're doing certainly better than no treatment, and certainly better than other types of treatments that have been tried. But in terms of where we're at, we have a lot of work to do to find more effective treatments or ways of making our current treatments more effective.
Mm-hmm.
I just want to add too that I'm a big fan of Melissa's work, and I just think that the work that she's doing with Jessica Grisham in terms of this attachment is really so promising, and really has a potential to really look at this disorder in a whole new way. So just wanted to say that.
Thanks, Carolyn. I feel that I didn't want to answer that question because I hate criticizing CBT in front of Randy. So I'll just say CBT for hoarding, it's what you need to do because it's what we have evidence for. We don't have evidence for other things. So that is what you should be doing if you experience hoarding symptoms. And at the same time, I think that researchers need to explore ways to potentially improve it. And I also think that people in charge of funding healthcare need to stop thinking that we can treat things in 10 or 20 sessions. If people have been hoarding objects since they were 16 and they're seeking treatment at age 65, it is just impossible to think that you can help someone clear out their whole house in 10 sessions. You're going to need 6 months to a year, and we need to start thinking about it as a chronic mental illness as we do with schizophrenia. I think that there's not going to be any quick fixes, and we just need to get that idea out of our head.
Mm-hmm. upset because you guys are all awesome, and it's already 1 o'clock, and I have a lot more questions to ask. So we might have to do a part 2 of this because I want to know the potential new directions of treatment and what we may be able to add on to CBT to make this work for a lot more people. But I do have some announcements to make on behalf of the ICDF before we wrap up. First, registration has opened for the ICDF Faith and OCD Conference. That's happening on May 9th. And also, registration has opened for the National OCD Conference happening in Denver on the weekend of July 8th through the 10th. I hope to see all the panelists there. But thank you guys all for agreeing. Honestly, I'm starstruck by the whole panel. So I really appreciate your time.
Thank you.
Thank you for having us. Great job, Kyle. This is the start. This is the beginning, and you're only just going up in terms of moderation. Really amazing job.
And can I just add, if you really want to start enjoying reading research articles, you should probably read what Carolyn, Randy, and I have written. I'm sure that'll take.
Here's a quick little plug. Great writers. And we do have someone asking for a part 2. So just look at your emails, guys.
All right. Technology will improve by then.
Yeah. Well, thanks, everyone. And thanks, everyone, for joining.
All right. Thank you.
Thank you.